The title of this talk is Head Impulse Test in the Evaluation of Jerk Nystagmus in the Emergency Room. The head impulse test is used to evaluate patients with jerk nystagmus in the ER. The aim is to establish the presence of an abnormal vestibulo-ocular reflex triggered by selective head movements. A vestibulo-ocular reflex abnormality is recognized by the failure of the eyes to remain focused during head movement and is confirmed by the presence of a corrective saccade at the end of the head movement. The head impulse test in the ER should be performed after extraocular muscle testing has revealed full motility. This is so for two reasons. The first one is that full extraocular motility establishes the relative integrity of the mechanism that produces corrective saccades. And the second reason is time efficiency. It would not contribute to the ER management of a patient presenting with normal eyes in primary position, normal right gaze, and normal convergence that during left gaze demonstrates limited right eye adduction and left abducting eye nystagmus to have a head impulse test because such a patient has an internuclear ophthalmoplegia, a diagnosis that dictates hospital admission and a brain MRI. So it is only after full extraocular motility has been established that we proceed with head impulse testing. The head impulse test, as we initially mentioned, relies on triggering an abnormal vestibular ocular reflex. In general, the principle of it consists of having the patient fixate at a short distance and then changing the head position. In the horizontal plane, let's say first to the left and then to the right, and in the vertical plane by turning the head 45 degrees to one side, let's say first to the right side, and then quickly from this static position thrusting the head down. Then back to a static position, then up, and doing the same but with the head rotated to the left. Why the different maneuvers? The purpose of the different maneuvers is to activate the different semicircular canals. When the head is turned to the right horizontal canal is stimulated. When the head is turned to the left horizontal canal. When the head is turned 45 degrees to the left and then thrust down, the right anterior semicircular canal is stimulated. And if instead from the static position the head is thrust up, the left posterior. When the head is turned 45 degrees to the right and then thrust down, the left anterior semicircular canal is tested, and up from the static position, the right posterior semicircular canal is tested. Please remember that the stimulation of one semicircular canal goes along with the inhibition of its coplanar mate. That is, when the right anterior is stimulated, the left posterior is inhibited. So if all attempts to produce an abnormal vestibular ocular reflex fail, the test is labeled negative. If, on the other hand, an abnormal vestibular ocular reflex is present, followed by a corrective saccade, after one maneuver, no further trials are necessary, and the test is labeled positive. A positive test supports the presence of vestibular apparatus or vestibular nerve pathology. Why? We will see why by going over a clinical case. A 12-year-old girl presents to the ER with horizontal right pitting nystagmus. She's dizzy. She has had nausea and vomiting for 3 days. Her exam confirms the presence of nystagmus. The rest of the neurological and the general exams are normal. A head impulse test is performed. Before I tell you the result of the head impulse test in this patient, I will tell you the mechanics of the head impulse test. There are many ways to conduct a head impulse test. I will describe the way I do it. The patient is asked to look at the examiner's nose while holding the head as shown. Then slowly, very slowly, in order to avoid the acceleration of the semicircular canal endolymph, the head is twisted 30 degrees to one side, let's say to the right. Once the head is turned, the patient's eye should still be looking at the examiner's nose. Then the head is quickly returned back to its initial position. The consequence of this action is to produce movement of the endolymph. In the left horizontal semicircular canal, the flow of endolymph displaces the cupula towards the utricle, producing excitation. And in the right horizontal semicircular canal, where the movement of the endolymph displaces the cupula away from the utricle, inhibition occurs. This maneuver will have one of two outcomes. The first possible outcome is that as we thrust the head to the left semicircular canal nerve becomes excited, while the right horizontal semicircular canal nerve is inhibited. I have now introduced the vestibular ocular reflex apparatus with the cerebral input involved in lateral eye movement corrective saccades. If you do not recall the elements in this model, view the video Horizontal Nystagmus in this channel. So the excitation of the left horizontal semicircular canal nerve excites the ipsilateral vestibular nucleus that excites the contralateral PPRF, and as a consequence, the eyes move in the opposite direction to the turning of the head, just enough to keep the focus through the trajectory of the movement. And ultimately, when the face of the patient is straight in front of you, the eyes are looking at your nose. We label this outcome as negative. The second possible outcome is that as the head quickly returns to the initial position, not enough discharges per second are generated by the left semicircular canal nerve to excite the ipsilateral vestibular nucleus. Hence, the line of sight moves with the head movements. And when the head movement stops, a time we will refer to as time zero, the eyes are out of focus. But shortly after, the cerebral cortex will be activated, stimulate the contralateral PPRF, and the eyes will focus on your nose again. This outcome is considered positive. So what was the result in our patient? It was positive. Hence, no further triggering maneuvers were needed. Thus, this positive result supports a peripheral origin of the nystagmus and indirectly votes in favor of an intact brainstem. Can you think why the presence of a corrective saccade indirectly votes in favor of an intact brainstem? I will tell you, don't sweat it. As you can see, the vestibular ocular reflex and the corrective saccade machineries have many elements in common, but not all. So, when the pathology of the vestibular ocular reflex occurs in an element that is not shared with the corrective saccade apparatus, such as the vestibular apparatus or the vestibular nerve, the vestibular ocular reflex will be faulty, but the corrective saccade will appear, as we just saw in our patient. On the other hand, if the pathology involves a shared structure, let's say the left medulla, as indicated by the added white circle, both would be affected. Hence, neither the vestibular ocular reflex nor a corrective saccade will occur. One more thing, head impulse test has risks. The risk is high in all people, young people with neck injury and in patients with odontoid hypoplasia, such as patients with Down syndrome and mucopolysaccharidosis. In this high risk group, it is better to avoid doing a head impulse test because the patient may end up vent dependent or paraplegic if the cervical spine is hurt. In low risk patients, I avoid the quick thrust to the side. I prefer to decrease the possibility of a spinal injury to initially slowly turn the head while feeling for unusual resistance. If no such resistance is found, then I go for the fast return to midline. Thank you very much for your attention.